Welcome to all my dear MOS members and the ophthalmic fraternity who has joined tonight for this 11th Journal Club meet. We have been holding it regularly on a monthly basis. A fantastic job done by Dr. Vaishal Kenya, Dr. Parul Deshpande, Dr. Sabyasachi Sen Gupta, and the whole team of the E-Journal Club. They have been doing fantastic work, and always we have had a fantastic panelist. This time also, we have Dr. Jitendra Jethani. Everybody knows about him. He is a pediatric ophthalmologist par excellence, practicing in Gujarat. We have Dr. Ramesh Kipunia from LVPI Hyderabad and Dr. Siddharth Kesarwani, who is at the GNR Clinic Mumbai. So welcome all the panelists. Today we have the coordinators from KEM, Dr. Shaili Mahajan, Associate Professor of KEM Mumbai. Welcome, Dr. Shaili Mahajan. And today's presentation is to be done by the postgraduate Dr. Komal Malpani on the article that is myopia control effect of deep focus incorporated multiple segments spectacle lens in Chinese children, results of a 3-year follow-up study. So it's going to be really interesting with a very good panelists, the expert panelists that we have. Absolutely, we are going to have a heyday today. Today, Vaishal is in the ESCRS. We have Parul to do the overall coordination. So I hand over the proceedings to Dr. Parul Deshpande. Welcome all coordinators, presenters, and the panelists, and my secretary, honorary secretary, Dr. Rajesh Joshi also. So over to you, Parul.
Yeah, thank you, sir. So I would like to welcome Dr. Jitendra Jethani, who's from Baroda, and to add on to his this thing that he is a PhD scholar in myopia progression. I think he's done that. And we have Dr. Siddharth Kesarwani, who has been an ex-consultant from LV Prasada Institute, and he has been practicing in Mumbai at JNR Clinic since last few years. So with this, I think we would just go to the topic of the results of DIMS in cases of myopia progression. So I would like to welcome Dr. Komal Malpani. Komal, can you share your slides? Sorry, I think the first, the introduction of DIMS and the available spectacles would be done by Dr. Shaili Mahajan. So can we have Shaili share her screen? Shaili, are you there?
Yes,
Yeah.
ma'am.
Yeah.
Is my screen visible?
Yes, yes.
Yes, yes.
Thank you, ma'am. Good evening, everyone. So today we'll be discussing a study on myopia control effect of defocus incorporated multiple segments spectacle lens in Chinese children. It's a result of a 3-year follow-up study done by Carly S.Y. Lam et al. It is published in British Journal of Ophthalmology. So myopia is a refractive error where light rays falls in front of retina. It is mainly associated with increased axial length. The prevalence being 21.15% in Indian population, and it is expected to be around 50% by 2050 worldwide. So if we see in current era, there is increase in digitization and increased screen time with decreased outdoor daylight activities, which shows the exponential increase in the prevalence of myopia in past 20 years. Almost there is a 20% increase in the prevalence. Also, the main age group is 5 to 15 years where there is the highest prevalence of myopia. So this is the target group which we would have to halt the progression. So if there is a progressive myopia, it increases risk factors for glaucoma, choroidal neovascularization, macular and retinal degeneration, and retinal detachments. That is why many interventions have been done to decrease or the progression of myopia. Like there is progressive addition lenses, orthokeratology, there are low dose atropine. So if we see the basic pathogenesis in myopia, when we give single vision lenses, that is concave lenses, the central focus would be directly on the retina. But if we see the peripheral rays of light, they will be forming an image behind the retina. That is called as peripheral hyperopic defocus. So the basic principle which we need to target to decrease or halt the progression is this, because when there is a peripheral hyperopic defocus, it's a stimulus for axial elongation. So the topic for today, that is DIMS lenses, are basically targeting this peripheral hyperopic defocus. And along with this DIMS lenses, this DIMS lenses were produced by Hoya, called as MOS. There are other spectacles like Zeiss Myovision, Essilor Myopilot Plus, and Essilor Stellest. So if we see how the DIMS, that is defocus incorporated multiple segment spectacle work, is that the central part of the spectacle will be having the corrected refractive error for the distance. Matlab the myopia chitna rahega, utna contact lens par would be there. But the peripheral 33 millimeter of that lens would be consisting a honeycomb pattern of circles and uncircled part. So what is this peripheral pattern is? The circled part of around 1.03 millimeter will have a myopic defocus of plus 3.5 diopters. So like in this, there is peripheral hyperopic defocus. So by plus 3.5 diopter lenses, there will be myopic defocus in the peripheral part of the retina. And the uncircled part would be again the corrected refractive distance correction. So, and the ratio between the corrected and the uncorrected part would be 50-50. So basically they are targeting the peripheral hyperopic defocus to become myopic defocus. So these are made up of polycarbonate material and availability is till minus 10 diopters, cylinder up to minus 4.5 diopters, and prisms up to 3 prism diopters. And in India, the cost is around 16,000 rupees. There is another lens called as highly aspheric lenslet target by Essilor. Even they target the peripheral hyperopic defocus. So if you see this lenses, again, the central part would be forming a focus on the retina, but there'll be 11 rings of aspheric lenslets in the periphery of these lenses, forming a 3D myopic defocus in front of retina. So this peripheral myopic defocus will halt the progression of the axial length. So this is the halt technology which Essilor has developed. So again, these lenses are polycarbonate material up to minus 10 diopters. They have been made, and cylinder up to minus 4. In India, it costs around 22,000 rupees. There is another lens which is on diffusion optic technology. So it has been seen that in the peripheral part of the retina, the contrast which the retina senses depends on the elongation of the axial length. So what these lenses do, again, the central part will be focusing the image on the retina, but the peripheral part will have light scattering centers that disperse light as it passes through the lens, creating a lower signal differences in the adjacent cones. Matlab, the peripheral part, the cones in the peripheral part of the retina will receive a different contrast than the central. But they also keep in mind that the peripheral part won't have any effect on the visual acuity or functional peripheral vision. So the vision would be normal, only the contrast in the peripheral retina would be changed. This will halt the axial elongation. This is diffusion optic technology. So these are some of the spectacles which are available for targeting the peripheral defocus part of the retina. And now I invite Dr. Komal Malpani. She is a third year MS Ophthalmology resident in SAIT GSMC and KM Hospital, Mumbai. She'll be elaborating on the article to be studied today. Thanks. Dr.
Komal,
Komal.
can you share?
Excellent, Saili. You have given an in-depth idea about the DIMS lenses. It's an eye-opener for those who are attending and who are not aware of this.
Thank you, sir.
Komal, can you hear us? Can you unmute yourself? Komal, you have to unmute yourself. Yeah, we can't hear you here. Can you go back to the first slide? Yeah.
Good evening, everyone. Today we are discussing about myopia control effect of defocus incorporated multiple segments spectacle lens in Chinese children. Results of 3-year follow-up study by Kali Lam et al. Purpose of the study is to determine if myopia retardation as measured by changes in spherical equivalent refraction and axial length continues in the 3rd year of the DIMS wear. If myopia retardation is exhibited in the 1st year of DIMS wear by original single vision control group, both groups will be compared with a new historical control group. Variables are first spherical equivalent refraction. It is measured by cycloplegic autorefraction using an open field autorefractor. Cycloplegia is induced by eye drop alkane 0.5% and cyclopentolate HCl 1%. Cycloplegia was considered achieved when the amplitude of accommodation was less than 2 diopters as measured using ARIA fluid. Spherical equivalent refraction was calculated by taking spherical power plus half cylindrical power. And second variable is axial length measured by partial coherence interferometry with RL master. Both these variables are measured at 6 months interval. Inclusion criteria were Hong Kong Chinese 8 to 3 years old children, spherical equivalent refraction of -1 to -5 diopters, astigmatism and anisometropia of 1.50 diopters or less, monocular best-corrected visual acuity of 0.00 logmar or better, acceptance of random group allocation and a mass study design. Exclusion criteria were strabismus and binocular vision abnormalities, ocular and systemic abnormalities, prior experience of myopia control. The study was a randomized control trial in ethnic Chinese children for 2 years. It was from August 2014 to July 2017. DIMS lenses were compared with single vision lenses and DIMS lenses of Hoya lens from Tokyo, Japan was used and the folio grant number is 7G5N and the funding for the study was also provided by Hoya lenses. In the first 2 years of study, DIMS lenses were compared with single vision and in third lenses and in 3rd year single vision lens user were switched to DIMS lenses. Historical control group was obtained for comparing 3rd year changes. Historical control group which was obtained was from clinical records from optometry clinic from 2017 and 2019. Criteria were same as original randomized control trial. So overall, we have 3 groups in the study. First group, DIMS group, which was taken from same group from previous study. Second group was control to DIMS, which was switched from single vision lens in previous study to control to DIMS group in this study. Since no group was left as control, they have created historical control group, data which was taken from optometry clinic. The study design is 550 candidates were assessed for eligibility, out of which 183 were eligible and were divided into 2 groups, DIMS group and single vision group. 93 were in DIMS group and 90 were in single vision group. Out of which 79 have completed the trial at the end of 2 years from DIMS group and 81 has completed the trial from single vision group. In 3rd year, which is our trial phase, 68 have joined the study and continued to wear DIMS lenses. And from single vision group, 60 has joined the study and were switched to DIMS lenses. So at the end, 65 have completed the study in DIMS group and 55 have completed the study in control to DIMS group. Right eye data was only used for analysis as there was no statistically significant difference between the right eye and the left eye data. Kolmogorov and Timjol test for distribution, unpaired t-test, Mann-Whitney Q test, or ANOVA test was used as appropriate. At the end of third year, 120 children have completed the data collection, and mean age for both DIMS and control to DIMS group was between 10 to 12. Baseline spherical equivalent diffraction was from -2 diopter to -3 diopters. Baseline axial length was 24 to 25 millimeters. And for results, at the end of 2 years, changes in spherical equivalent refraction in DIMS group are -1.34 diopter, -0.34 diopter, which is significantly lesser than change in the control to DIMS group, which is -0.87 diopter. But at the end of third year, it has increased by only -0.18 diopters in DIMS, which is comparable with the increase of -0.05 diopters in control to DIMS group. Similarly, at the end of 2 years, changes in axial length in DIMS group are 0.20 millimeters, which is significantly lesser than changes in control to DIMS group, which is 0.49 millimeters. But at the end of 3 years, it has increased by only 0.11 millimeters in DIMS group, which is comparable with the increase of 0.08 millimeters of axial length in control to DIMS group. There was no statistically significant difference in myopia progression and axial length elongation in the third year between DIMS and control to DIMS group. DIMS compared with historical control group, 76 children were analyzed in historical control group. Mean age was from 12 to 13 years. Changes in spherical equivalent refraction is -0.35 diopters and axial length is 0.18 millimeters. The myopia progression in DIMS group were significantly less than historical control group. Here, the change in historical group is -0.35 diopters, which is more than the change here, which is -0.18 diopter. Similarly, the change in axial length here is in historical control group is 0.18 millimeter, which is significantly larger than -0.11 millimeters, which is in DIMS group. In DIMS group, over 3-year period, mean change in spherical equivalent refraction is -0.52 diopters, and mean change in axial length is 0.31 millimeters. Findings are comparable with the corresponding finding in the 3-year trial with dual power contact lens by Chamberlain et al. And the 3-year trial with multifocal soft contact lens by Vallin et al. This study's progression findings were nearly 50% less than reported by Cheng et al. In the 3-year trial with bifocal and prismatic bifocal spectacle lens, which included subjects with fast myopia progression. The limitations of study were our cohort was not randomized since control group switched to DIMS. Historical control group was started in 3rd year of study, so comparison cannot be done from start of the study. The other factors affecting myopia progression, such as outdoor time, myopic parents, near vision was not considered. Effect of these lenses on visual acuity when viewed from mid-peripheral part of the lens is not measured, and any symptoms post-wearing was not considered. Binocular acceptance was not evaluated. The time period for which the lens should be worn was not clearly specified. Thus, the 3.5 diopters achieved maximum anti-myopic effect was not mentioned. Thus, 50-50 area ratio achieved maximum anti-myopic effect was also not mentioned. Here in this lens, these circles, they have the power of plus 3.5 diopters, while the remaining area has a refractive power of the patient's eye. So this 50-50 ratio has not been explained. The feasibility of these lenses in terms of cost in Asian population should be considered. DIMS show decrease in myopia progression in the period of 3 years. Further follow-up is required to determine its long-term effect. According to MEDIS protocol, study questions were well defined. Study population, inclusion and exclusion criteria were well defined. Study period was well defined, randomized, and it is a randomized control trial. Controls were matched for baseline parameters and follow-up interval. Measures of outcome were appropriate and no inter-observer variability was there. Statistical tests were advanced and was done using software SPSS v.20.0. P-value is significant in this study, thus the interpretation is appropriate. Since the study was done in Asian population, adequate sample size can be extrapolated to other Asian countries as well. Thank you.
Excellent presentation. Very nicely put up.
Yeah.
Dr. Komal.
Thank you, Komal, for a very wonderful presentation. Komal, can you unshare your slides so that we could... So I think with this, we would start with the discussion. So can we have the comments from our panelists, Dr. Jethani and Dr. Siddharth, about the article? So Dr. Jethani, yeah.
Yeah, I think it's a wonderful article, and I think Dr. Komal, my congratulations to you. You summed up very well. Most important is the limitations which you tried to highlight. Apart from those limitations, I don't think we should go into details of it again. But if we want to discuss the article, those are the only things which we can discuss, because otherwise, according to Mary's protocol, we saw that it was a wonderfully done study and they followed most of the criteria. There was hardly any inter-observer variability. So, and they chose only right eye to evaluate the data, and P-value was significant. So there is nothing much we can dissect except for the limitations. So, I mean, if we want to go into the limitations, one of the limitations, of course, is the cost, which she already highlighted very well. Especially in India, it's a cost-sensitive country. But if we go back to more scientific, scientific detailing, the most important are. Can we show those slides again, because they're wonderful points. I mean, most of the points. Can you share your slides? The last limitation, 3 slides. Yeah, the previous one before that. Yeah. So the third point in this, I was discussing this in Calcutta. I think a lot of small things which have not been considered, and I think there are 2 important things for me. One is that axial length, because most of these patients are axial myopes. So the time period for which glasses should be worn was not really specified, and it is very difficult whether children were actually wearing it or not. But for me, can we go to the next slide? Yeah, for me, the third point, because the myopia is multifactorial. Axial length, normally atropine is criticized that, the atropine doesn't give a good, robust data on axial length, whereas most of the other studies do give good data. If we go into the chart of comparison, we will see that, the standard deviation is very high when it comes to axial length, and rightly so, because if you go into axial length measurement, there is bound to be a high standard deviation when we are talking about 0.04 millimeter of difference in 6 months. It's a very small difference to corroborate. So, so you see this particular point at 6 months, it is 0.04 millimeter changes in axial length with a standard deviation of 0.1, and with 0.1 with a standard, which means that there have been some patients that has been either on other side. Some axial length patients may have actually a lower axial length compared to the previous data, which also happens in our atropine studies also. So that was just a point, because axial lengths are difficult to measure. The other things are that, whenever we talk about hyperopic defocus being the focus of controlling of myopia, what we tend to forget is that not all the patients who are having hyperopic defocus. So remember, we give glasses, single vision glasses, to most of the children, and there are a lot of children who actually do not progress. Not all the children do progress. So if there is hyperopic defocus which is contributing to myopic progression, and it is the sole reason, then all the children, be it urban, be it rural, everybody should progress. And another important point, which is that, it is other way around also. This myopic, hyperopic defocus is also there in hypermetropic patients, but their axial length doesn't progress. We will not go into the detailing of that because right now we are discussing purely into myopia because there are multifactorial things. So I think other factors, especially outdoor timing, near work, parental myopia, most of those factors are huge influencers when it comes to the actual progression. So that is my dissection of the study. But wonderfully presented.
Thank you, Dr. Jitendra. Siddharth, your comments, please.
Thank you. And Dr. Komal, that was a nice presentation. But my only gripe is, why have you omitted the graphs? The graphs are very important because they will give a lot of the information that you cannot make out from the tables. So especially the graph shows that, in fact, the control to DIMS, I don't know, but it decreases and then the myopia reverses actually. I don't understand how that happened. The other thing is regarding, Jitendra has pointed out rightly so that it's a good study, but then the journal club, we will have to find some problems with it. So my problem is with the age group that has been taken. So the baseline age group is 10.5 plus minus 1.5. And by the time the third year starts, most of them would be 12.5. So interpreting the results at 12.5 in simple myopia and extrapolating it to 6.5 would be difficult. I think that age group is a different age group where myopia really starts to slow down considerably. And we all would have experienced that by the time the child is 14, 15, the progression really slows down. So we are already entering a phase where myopia progression would slow down. So it's difficult. The other thing is, it's remarkable how in 3 years, the progression in both the groups was so little. I mean, in one group, it was 0.5. The other group is also not far behind. Even though when you talk about the relative risk reduction, it is very high. But if you look at the table, the absolute values are really unbelievable. Very little. So obviously something should be half of other because the quantity itself is small. The other, if you would have seen the graph, in the first 2 years, I don't know if you can put up the graph, but that would have been very important because the one point is which the author...
I'll just see if I can share that this thing. You can comment it at the time.
Yeah. So one important thing which if I was the author, I would have mentioned is probably the effect weans off after 2 years. Because in the third year, the decline in myopia progression is more in the newly introduced group rather in the older group. And if you look at the first year of the same group, they have a very good effect. And the first year of this new group is also having a very good effect. So that is something to ponder about, although it is just a hunch that probably with time the effect will wear off. So that needs to be studied, I guess, because in this, the newly introduced group also, there is much more effect than the people who had continued to wear. And in the first year of that group, the effect was much more than what it was in the third year of the same group. So that is one point I think which maybe have to be looked in the future, probably. Yeah, Jitendra.
Yeah, I just want to say that maybe the dosage needed after first year of effect should be more. I mean, again, another hunch, maybe the 3.5 is not, it's sufficient in the first year, and then maybe because everything has settled down, we want to go to 4.5 or something like that. I mean, another hunch to study. I mean, we can all speculate.
Yeah, so this is the graph I was talking about. Look at the A graph, first graph. you would feel as if the effect in the blue line is slowly waning off. And when you compare it to the last year of the red line has a dramatic effect, you know. It in fact reverses it. So
Reverses.
yeah, so that's okay. I mean, sometimes numbers can play tricks. I'm not I'm not doubting the data, but I'm just saying it shows that the first year of the introduction would have maximum effect. That is what this graph is telling me. And I find it very difficult to always correlate it with axial length. Somehow they never match in most of the studies. What's happening in the refractive error group versus what is happening in the axial length group. It never matches. So somehow I just look at the refractive errors more than the axial length. So the other issue is the inclusion criteria, which I have already told. I think in all these studies, the inclusion criteria should be people who are progressive myopia.
Yes.
So they should include only people who have increased by X amount in the last year. The problem happens when they randomly select, and most of them would anyways not progress.
Not exactly.
So that just dilutes the sample, you know. So a sample of 300 starts behaving like a sample of 150. So it's a watered down, because you are trying to see if an intervention reduces the progression of myopia, and you include everybody who has come with myopia and not with myopia progression. So the inclusion criteria should be myopia progression and not myopia per se. So those are my points, but I think people can correct me.
Yeah, thank you, Dr. Siddharth. So with this, I would just ask Dr. Sabyasachi to give his comments about the article, the statistical expert for the JC group. Yeah. Dr. Sengupta?
Yeah, Dr. Parul, I'll just share my screen quickly.
Yeah.
It's like everyone has said, because this is a JC, we need to, criticize the paper a little bit. Okay, a few things, when you look at the authors and their affiliations, these two authors that are marked are actually part of the Hoya Corporation itself. So if you see these, they are from the Technical Research and Development Department from Hoya, right? So this is an entirely, this is something that we need to understand, because, if the company which is sponsoring the study and, providing all these expensive lenses to 200 children is, if people from their team not only are, influencing the study, but also are co-authors, right? So that's something that we don't see very frequently. So that's something that is sort of questionable for me. Then if you see all of these authors are actually optometrists, and, sort of on record or off it, I was, part of a team which the Hong Kong government actually hands out, funding for these, like something like the ICMR. So I was part of a team which actually granted funding, and if you know the amount that was given to them, you will be, flabbergasted. So it was more than 1 crore rupees, for studies like this. So, and that's just to put in perspective that, the sort of interest and also the support that these people get is humongous. Coming to the actual study, if you look at this study design, this is somewhat like a crossover study design where, but the actual crossover study is where both the groups actually cross over to the other side. That might have actually made sense. After using DIMS, if you go over to single vision, does it actually suddenly increase progression? So that has not been done. Of course, when you have to do a crossover only for one arm, then you have to break masking, right? So this original study was a randomized clinical trial and all of that, but this one is not. Okay, now, coming to the results, the mean age is again not mentioned here. Only the mean age of inclusion is, is mentioned here. But if you look at the, so I think 8 to 13 was the overall age with a mean of 10. I think Siddharth has already told us that. Again, I think Siddharth has already brought this up very nicely, where in that baseline of all these kids was between -1 and -5 and not more than that. Is it applicable to those showing rapid progression? So if you feel that I have given single vision and somebody has progressed, say for -2 diopters over a year, now I'll switch over to DIMS and I hope it's not going to progress. That is something that this study does not answer, right? So that is a very important point that everyone should understand. The ATOM studies do address this, but DIMS, this study does not. Now, when you're looking at changes in, when the change in refractive error is not going to be uniform year on year, right? From 8 to 9, it's going to be probably jumping more, and from 12 to 13 is not going to be jumping that much, right? So that is not uniform. So that is not linear. So there are ways to do this better. So there's something called quantile regression. Someone of if any of you are interested in reading about it, and I have a LinkedIn post on it as well. So you can just scroll through my profile. So quantile regression really can help when there is non-uniform intermittent refractive error with increasing age. Yeah, so this is a 2-year double masked randomized clinical trial, like I said, but then the current one is not really exactly the same study design. A couple of more things, when you talk about historical control groups, there's a whole gamut, or a whole domain of research which is coming up, which is called synthetic data. It is actually retrospectively collected data, but then you're putting all of that data through a lot of strict inclusion and exclusion. And so if say out of 1,000, say 50 patients are could have been part of a randomized trial, then I will take data from only those 50. Now that is a lot of people are not comfortable with that, but this historical control group really falls under the large domain of synthetic data, which again you can Google and get more information about. Again, they said right eye data were only used for analysis, and repeated measures ANOVA and post hoc pairwise comparison using Bonferroni's corrections. Now, why repeated measures is used because we are measuring these again and again, right? At 6 months, at 12 months, 18, 24. So there is, so if somebody is going to progress more, the chances are that he are going to progress more and more and more. And somebody who doesn't may not, right? So the refractive error at a point in time may influence the next refractive error also. So these are repeated measures. Now, if you add data of both eyes into this, that is another level of repeated measures. So it is better to avoid that. Therefore, only the right eye was taken. And the right way to do it is a repeated measures analysis. However, this multiple linear regression approach that they have used is probably not the best one. And like I said, quantile regression should be used. Also, if you look at this, this chart where initially there were 183 who had 93 in one group and 90 in the other. But in the 3 years, 65 and 55. So 55 out of 90 are actually present. So that's about 60% of what was initially taken, right? So this is the group which we're interested in, isn't it? Where from SV to DIMS. So only about 60% of the original, actually entered into that. So then who were the 40% who were left back? Were they the actual progressors? Or how did that go about? It's something that they have not given us information about, isn't it? So whether these 40% actually were the worst ones, and they were the progressors and they benefited more, that would have really helped us to understand. So this 55 out of 90, that is the 60%, they may actually have been the non-progressors or may not have progressed as much, or so 40% loss is relatively large, and we don't know who the 40% lost were. And lastly, I think Siddharth has already pointed this out to us. This change, so let's remember that the y-axis is a change and not the absolute value. So the change is lesser. So here, once the intervention is done, the change or the progression is lesser, is I think what this is saying. But yet, I would have expected it to flatten out, but such a dramatic uptick is probably something which is, we might want to. So that clearly shows that I think, that these 55 out of 90, there's something to do with that, where these are slightly different from the, the 40 who have lost. So, so these are some of the points that I thought, we can discuss.
Thank you, Dr. Sengupta. I also just had one comment. So whatever articles that I had actually gone through regarding the DIMS or the aspheric lenslets, or comparing one design with the other, most of the authors were either from the Essilor group, from the Hoya group. So, so none of the studies I got where there was no, this thing. So most of the studies which I went through had this involvement of all the authors with the concerned kind of DIMS lens.
But Dr. Parul, that is the reason is the intervention is costly. And that's why unless you have a funding, no institute is going to do the study. So ultimately the funding or the sponsorship from the company is a necessity. Absolutely. Nobody is going to spend money from their institute to do this study. And you don't expect patients to get enrolled and pay for their glasses themselves. So yes, that is a big problem. But that happens with all the new interventions. So it was there with Lucentis also, because Macugen also. All the initial studies were company sponsored because nobody is going to purchase Lucentis and probably.
So can I just so having sponsorship and that is great, but having them as co-authors is another.
I'm not defending
probably
it.
not
I'm probably just saying why
Definitely
there
not
are not many studies because the intervention is costly.
But
No,
authorship is probably not such a great idea to do that.
If you go through the halt lens data, the study has been done in the medical hospital, which is run by Hoya. Then hospital is also Hoya's hospital. Authors is okay. The whole hospital is owned by Hoya. Not Hoya, Essilor. I'm sorry. The other study, halt study, the whole hospital is owned by Essilor. It's Essilor's hospital.
Okay. Yes.
I would like to ask,
over to you.
I would like to ask 2 questions. Dr. Jethani, sir. So if you see a child with progressive myopia, what would be your first choice? Like, is there any child you would prefer low dose atropine or progressive addition lenses or TIMS lenses?
So right now, I actually start with low concentration atropine, and if they come back as progressors, I may give progressive lenses. I will add 1.5 or maybe 2 also, depending on the amount with black. But DIMS lenses are, honestly speaking, it is very expensive. The whole point is I'm from Baroda. It's pretty expensive. Even if even the doctors who are like in Baroda, their children also they also think like a couple of times before thinking about going for DIMS. They're pretty expensive. 15,000 for a pair of glasses, and for the sake of study, because I'm a lot interested into myopia, we have started giving them, like, we get lenses at 9,000. We give them at 10,000, sometimes 9,500 also. But because we want to collect data that whether it is a good lens, whether it is useful or not. Just one point I would add that at least in my own work, I have seen that progressive lenses are equally effective or like very good. They're in 12 to 15 patients who have come back in last 8 to 10 months with atropine and on progressive lenses. They are doing good. They are actually doing very good.
So you're using low dose of 0.01%, sir, right?
Yes.
Or you are you give it only once a day, or you even increase the dosage if the children are
I do increase the dosage also. I'm guilty of that too.
Okay.
I give.
But how many times, Jitu? Jitendra, how many times do you put 0.01 atropine? Daytime,
Twice
night time?
a day also, sir. Twice a day. I tell them to put it twice a day. In our study, we have not found any problems with near point of accommodation. One patient I saw having esophoria, not even tropia, and we stopped him and we started him on progressive glasses, and he turned out to be okay. So twice a day, we give them twice a day. We are even using 0.05 also, but 0.01 most of the patients. But I was saying that progressive lenses are equally good. I mean, they're pretty good.
And what about progressive contact lenses?
Never use them, madam. With kids, we are very maybe old-fashioned, or we just are little scared what we will do for those kids. Like that would be very scary if something happens or something goes wrong. I don't know whether anybody else uses progressive lenses for kids. Siddharth?
Yeah, see, so I have a step ladder pattern. Same, I do give low dose atropine once a day. If progression continues, twice a day. Progression continues, progressive glasses plus twice a day. Progression continues, Hoya.
And by this time, progression stops because Hoya has come, or probably the age is beyond 12 years.
Yeah.
So, or the child has spent 15,000 rupees. The eye doesn't want to grow further. It's too expensive to grow.
Anyway. So, but if you were to prescribe TIMS lenses, so how will you prescribe, like pure myopic refractive error or based on spherical equivalent, and will you keep any margin of error while prescribing? So suppose if the child progresses, now he has spent 15,000 and he progresses by -0.5. So You keep
No,
a
you don't.
margin.
No. I mean, as a scientific people, we don't keep any margin. I mean, the margin of error is very low for all the doctors, and that is why we are at the receiving end of most of the patients, and that is why Ayurvedic doctors are much better than us, because they keep margins. We don't keep margins. But see, all my studies, all my work, as Siddharth said, we have taken only progressors. We don't take. So we wait. Most of the children are progressors, and for us, DIMS lenses are given to. So whenever we will publish our findings, it will be DIMS lenses in non-responders to atropine. I'm yet to use a DIMS lens directly. I've never used it. I mean, wouldn't even think of using a DIMS lens without using low concentration atropine. Simply because
what is the power that you prescribe? Suppose it is a -1 lens. So do you prescribe a power of -1 of DIMS? How do you prescribe that lens?
The same. The same prescription.
-1. Yeah, same prescription, sir.
Same.
Okay.
And that is the problem. That is one of the problems. The basic assumption is everybody's posterior segment is same, but that's not true. So somebody might require plus 3.5 to correct his hyperopic defocus. For somebody else, it might be plus 5. You don't know how oblate his posterior segment is. And see, that's why, I mean, it may work for some people who actually fit the glasses as opposed to the glasses fitting somebody. So if because there's only one size fit all, plus 3.5 add for everybody. And we cannot change it because we don't have any other measure unless and until you do a peripheral refraction, which is very difficult to do in clinical practice. Even they are not doing it in research also.
Why can't we do a B scan to find out the exact shape of the posterior segment? And those who have proper this thing, only we prescribe 3 plus 3.5. Rest we exclude.
No, sir. It is not just about the shape. It is also about how much so the refraction is based on the corneal curvature lens and the recipient bed, which is the curvature of the posterior end of the retina. So all three of them, as Siddharth said, you can do a refraction. He rightly pointed out. You can do an open field refractor. I really don't know. I have not worked with an open field refractor myself. I don't know how much accurately you can do it with kids. If you give them a target, whether they are actually looking at it is very difficult. I mean, they have a lot of studies.
My problem is that you are treating somebody based on studies done on monkeys without any corresponding measurement in human beings.
Okay.
Yeah.
Siddharth, just to put the question which Saili has said. So when you are prescribing DIMS, are you correcting myopia fully or under-correcting the way we
fully? You have to correct it fully because under-correcting myopia itself is a stimulation for growth. And when you correct myopia fully, that's because the child is going to start seeing blur in the mid-periphery. So at least the center has to be clear. The mid-periphery, they get used to it. But I'll give you an analogy now because we have finished the journal club. I'll give you an analogy. I don't know why I am doubtful it works. Probably why I'm doubtful that it will work as well as ortho K or say a multifocal contact lens. It's because of that 50-50% ratio. So you think of somebody who's undergone pan-retinal photocoagulation, and they have these spots all over the retina, and with with proper retina in between the spots, and their loss of field is not very dense. It depends on the density of the spots.
Correct.
Now you extrapolate that analogy to this density of these dots. Now, if you have left behind enough spaces in between, is that not hyperopic defocus interposed with myopic defocus?
Correct.
So one thing is pulling it in one direction, another one is pulling it in another direction.
Correct.
So you don't know.
So what you say, Siddharth, what you say, it should be total defocus, no normal.
But then that will give a tunnel vision to the child.
Tunnel vision to the child.
Okay.
So that is the challenge.
So what we did was, just to find out whether it gives a tunnel vision or not, we did visual fields in these children.
Okay.
We found that visual field that is 30-2 was good, but then of course 30-2 is not the one which we should be doing. We should be doing 60-degree field, but we did 30-2. 30-2 is not affected by that 9mm ray.
Exactly. So that's what I'm saying. See, if nothing is affected, then even myopia will not be affected.
Ah.
I think, Siddharth, there is a study where they have looked at the distortion that the child faces in the lateral horizontal movement, so the nasal and the temporal. And
Yeah, so I have asked my patients what kind of, there are some patients who are older, 11 and 12. So they tell me that we see blurry in the beginning and then we know it just goes away. So somehow there is some neuroadaptation and it just gets cancelled out. All of it gets cancelled out. So all those blurry spots are probably, filled by the clear spots. So they cannot make out anything after that. And so there is some neuroadaptation happening here also, just like it happens in your IOLs, where your near focus and distance focus, they become seamless over time and you are not able to see two images. Otherwise, all multifocals would see two images all the time.
So even with progressive glasses,
yeah, same
thing. You have distortion in the periphery, but we still get used to it.
Yeah.
So, ma'am, in that study, the acceptance and adaptability of DIMS lenses, so they have come to a conclusion that the peripheral part, there'll be only one Snellen's decrease in the visual acuity, not much, but they have said the acceptability of the children towards DIMS glasses was less, but then eventually when they were told that it would decrease progression and all, so the acceptability increased to almost 90%. That's what the study said. But again, even that was by optometrist and not, I don't think that was done like properly without funding and all. So one more question, sir. So would you prescribe DIMS lenses in amblyopia or in strabismus kids?
Why? Okay, so amblyopia, it's a progressive myope, and then I would be prescribing amblyopia. Honestly, never had such a situation, but amblyopia, I would think that I would wait at this point of time, because in strabismus patients, I actually don't prescribe low concentration atropine also, for the fear that, it may change things. So at least not at the first go. If there is this thing, I may prescribe, but in a very controlled manner. So I would be a little wary of prescribing this in strabismus. Although theoretically you can, but then if there is I never thought about it truly. But if your eye is deviated, maybe the distortion would increase because he's not fixing in the center, and the fixation point is very important. The marking of these particular lenses, even the company is very touchy about it, that they want to send their own person to mark the centration of the pupil and everything. So I would not prescribe this at least in a strabismus patient. Amblyopia, maybe I would like to. I'm less bothered about his progression of glasses and more bothered about his visual quality when I talk about amblyopia. So I would like them to improve first, and then maybe I may think about giving them these lenses.
And those with anisometropias, is it any different?
Right now I have trouble prescribing them to normal children.
Yeah. No, that's true. See, we are just trying to discuss it out. I know it is not practical because anisometrop patients having progression, they have two set of problems. One is anisometropia itself, and second is that they are progressing. So even anisometropia patients, I'm a little bit afraid of giving atropine also, because I'm very possessive in those patients, because they may go into some changes in strabismus. They may go into esophoria very quickly, because we don't know. The anisometropia itself may be a problem. So I would try to restrict myself at this point of time, maybe.
Yes, sir. And at what period will you like to wean or stop giving DIMS? Stop the child, ask the child to stop wearing DIMS?
These are very early days. I think we have just, I have some 18 patients on DIMS, and it has been only 7 months. So I have no idea. Maybe after 3-4 years, maybe maybe first of all, as I am also very skeptical whether it will work or not. So let us see whether it works or not. And it may be, just another thing which came, and we all will be witness that this just came and this just went away. Like so many things. I mean, there's so many things which come. There's so many things which came in the past, like cam stimulator. There's so many things. I mean, it's just one of them. We don't know. Let's wait and find out.
Currently, my advice would be give it to the rich kids who will not miss their 15,000 rupees, and let the results come out before you start prescribing left, right, center. Because wait, it is still, the jury is still out, and there's a lot of work still needs to be done. Before it can be called a preferred practice pattern, it is still not the preferred practice pattern. It's
the moment it becomes clear that it works, there will be good copies. We are very good. Indians are extremely intelligent tribe. So there will be a lot of copies. Second, government of India may put it into price control. Who knows? if it really works. No, but it should work. I would say that would be great if it works. Because we have seen that even with atropine, after 1 year or 1.5, 2 years, the effect is not as strong. And इसमें तो study में ही दिख रहा है कि the effect is not as strong. And we are all skeptical whether, because there's a lot of skepticism about the whole theory of, I may be saying very big things, but the whole theory of hyperopic defocus, why it is there for some and why it is not there for others, and why it does not work for hyperopia, because all of them are in hyperopic defocus. All of us are in hyperopic defocus. So what is the trigger? What is the biomarker which stops us from progressing? There's so many things. I mean, environmental factors are actually a lot more important than what we give them. I mean, they're quite important.
If to understand the basis of hyperopic defocus theory, it came from Earl Smith's experiments, where infant monkeys, their central retina was ablated and the peripheral retina was given a hyperopic defocus, leading to a myopic defocus. That's where he said that the fovea doesn't really play a role in myopia progression. Now that all these points are very important. Monkey, infant, okay, growing eye, and the effect over a short period of time. All those 4 things have been negated. Here is a human being, which is not an infant, and you are leaving it over a long period of time. So everything is extrapolation beyond data. Every single thing. So wait.
Okay, we have Dr. Avinash Ingole also from KM Hospital. He's heading the department. So Dr. Avinash, I welcome you here. And
thank you.
I'd like to know if you have any comments about...
Before commenting, I would like to thank BOA and MOS, especially Parul, you, Rajesh, Dr. Taswala sir also, for involving Department of KEM and GSMC for this wonderful journal club. 2-3 things I wanted to comment on is the kind of patients what we see in general hospitals. Because of the financial constraints, it's very difficult to buy even single spectacles also. So forget about buying DIMS, it's out of question. Another thing, this study does not mention, suppose a child needs 2 or more spectacles where they were provided, or three spectacles, because single spectacle itself cost around 15,000 rupees. At the most, that atropine, yes, fine, but then we have our own limitations in our set of patients as such. I did like comments from Dr. Siddharth, because he's more methodical and practical also in dealing with childhood myopia. There are certain limitations, but this study was done for 3 years only. That means it is a part of earlier study, and this is a part 2 of that earlier study. So the same patients were followed up for 1 more year. And as Dr. Sabyasachi also said, that it's a company funded. So obviously not everything should be taken granted as such. Only the time will tell whether these lenses are effective or not effective. For that, I think this study was done in the Chinese people. Another point that was mentioned is in our set of patients, not single factor plays role for progression of myopia. There might be multiple known and unknown factors. So if we can stop it, especially in axial myopia, and that will be better. But I think we will still wait for whether these lenses are effective in long run as such.
I think we are very short of time. So before we conclude, just two questions, one to Dr. Siddharth and one to Dr. Jethani. One is that how long should we continue before saying that, okay, it's not working?
At least 1 year.
1 year. So what is the amount of myopia progression that if you see with these glasses? So will you just stop or and switch to the other modality?
It should be at least half of what it was previously, because that is what the glasses promise. So if somebody had progressed by 1 diopter in the previous year, if he is better than 0.5, then I'm okay. But if he's 0.75, probably not working.
And Dr. Jethani, what about the astigmatism part? So if you have a compound myopic astigmatism with a higher astigmatism, would you still want to go with these kind of glasses?
I don't think astigmatism is a factor, because if they can, I mean, if we are convinced that these glasses are going to work, then astigmatism is not going to, I mean, really make a difference, because the upper limit is, I think, 4 diopters of astigmatism, and the upper limit of spherical power is 10 diopters. But when you prescribe them, they count it like -6 with -4 is the upper limit. -6 diopter sphere with -4 diopter cylinder. So that is -10. So beyond that, they will not give. I don't think astigmatism would be really stopping me from prescribing the glasses. Yeah, in our work, most of our work, we do a very strong control of, we don't take spherical equivalents. We take pure axial length and pure spherical powers. And a lot of keratometry, we do a lot of keratometry, and we keep telling people that you should do a lot of keratometry, because spherical equivalents are biased by the progression in astigmatism also. Although in this particular study, it was beyond 10 to 12 years where we don't expect much of changes in astigmatism. But in younger age group, yes, changes in astigmatism may also give you an error in us reading that, you know, spherical equivalent has increased or decreased.
And any experience with orthokeratology lenses? So do you, and Siddharth, yourself? I think they have been introduced in India now from the...
They are there. I mean, I have...
They were there before, but they did not
even
have...
myopia control. Myopia control is there. I actually was interested. I got the pair. I thought of giving it, but in Indian scenario, it becomes cost is one, and second is hygiene. I mean, very, very risky.
Yeah.
Very risky.
Yeah,
I would like to know opinion of if somebody else is using ortho-K for myopia.
Siddharth, you have any experience?
Ortho-K, no.
Okay.
But I wanted to highlight that point about the magnitude of myopia. I see theoretically, if you look at the hyperopic defocus, if it is the oblate, if the cornea, retina is less oblate, and you have plus 3.5, it is more likely to work as to compared to a very high myope, where it becomes more oblate, and then 3.5 might still be behind the retina. So I think you should limit it to 3, 4, 5 and not go beyond.
Okay. I think this, yeah, I hand over to Dr. Rajesh Joshi for the thanks.
Just to comment before Rajesh takes over. Fantastic journal club meet. I think this is the last of the journal club meet during my tenure. A fantastic job done by Parul, Vaishal and his team. And today's panel discussion was very interesting. New concept about DIMS. Very few of the general ophthalmologists must have known about it. So threadbare discussion on the article also. Very well taken. Thanks a lot to all the panelists. And of course, Parul, Dr. Saili ma'am, and also Komal for excellent presentation and an overview on this article. And of course, Sabyasachi. I think he has left already.
He left, so he has another meeting. So he has written in the group.
So, yeah, over to Rajesh, and then we'll have the entoed video to be played as always. And a big thank you to all of you.
Yeah, that was really a wonderful discussion. The crux of today's discussion is myopia progression in children wearing DIMS glasses is less than single vision glasses. However, still a long way to go. Thank you, Dr. Jitendra, Dr. Siddharth, Dr. Avinash, and Dr. Sabyasachi for critically analyzing the article. Really valuable inputs. Residents will definitely benefit from today's journal club. I thank Dr. Komal for presenting today's topic. Thank you, Dr. Saili, for highlighting on various spectacles for myopia control. Many thanks to coordinators of today's journal club, Dr. Parul, Dr. Vaishal, and entire journal club members. I'm also thankful to office bearers of BOA. I'm also thankful to all those who are joined on virtual platform, and thanks to Entor for the technical support. Over to Said for the video.
The video and the gallery view shot. Everybody put the video on and smile. Sayed, please take a gallery view shot and I play.
Yes, sir. I've taken, sir.
Thanks. Go ahead.
So I think with this,
we call up
our journal club. Thanks, Siddharth. Thanks, Dr. Jitendra, for the wonderful.
Jitendra is left, I think, already.
He's left. Yeah. Okay. Thank you, everyone.
Bye. Take care. Good night, everybody.
Yeah. Good night.
Good night.
Good night.